So this is the pre-run mathematics that I've simplified in this way, that the LM maximum diameter was around 4.7, but the internal luminal minimal area or the diameter was around 2.8 millimeter. Whereas the LAD is predominantly 4 millimeter maximum vessel size, and the ostium was around 2 millimeter, and the proximal was around 2.7 millimeter. And the left main distal part is around 4.5 millimeter maximum size diameter vessel, and the inner diameter was around 3.6 millimeter. So I thought of taking the Wolverine ballooning. It was around 3.5 into 10 millimeter Wolverine cutting balloon, and I inflated it up to around 10 atmosphere of pressure. And after the Wolverine ballooning, I think there is the area looks a little bit better. So then I went for a 3.5 into 38 millimeter onyx. I took onyx because I will have to blow it up to around 4.5 for the 3.5 millimeter stent. And I did the ostial flaring also. And then subsequently, I post-dilated the LAD part with 3.5 into 12 and post-dilated the LM with 4.5 into 8. And this is the post-run IVUS. I've got a images snapshot for the sake of time. I'm just skipping it. And after the post-run analysis, what I found that I could achieve around 4.5 millimeter of left main ostial diameter with an area of around 14.5 millimeter square. And in LM distal, I could achieve up to 4.1 millimeter with an area of around 11.7 millimeter square. And in LAD osteoproximal, I could achieve of around 3.5 millimeter with an area of around 8.2 millimeter square. And in LAD proximal, I could achieve around 3.5 millimeter with an area of around 8.8 millimeter square. So as a whole, the result was quite satisfactory. This is the end result. So the post-operative follow-up is excellent and the patient is completely symptom-free. So ostium LM intervention, the definition that any lesion within the 3 millimeter of the ostium, that there are quite 3 important problems: high calcium and fibrous content, higher recoil, and higher neointimal hyperplasia. There are the 8 challenges that we take care of when we deal with any ostial LM intervention, like vasospasm. We'll have to exclude that I excluded during the angiography. Poor guide support and coaxiality. Then ischemia due to pressure dampening, aorto-ostial dissection, Milan seeding, risk of dislodgement, geographic miss, and stent deformation. So my take-home message from this case would be LM ostial intervention is always very challenging. Proper planning is extremely essential. Intracoronary imaging is practically mandatory in LM PCI, and we should always be very vigilant about the distal catheter tip and the proximal stent trot. And unless there is a financial issue, it is always better to take care of the area with the help of some plaque modifying gadgets like cutting balloon and others. Thank you.